So fundamentally, we're looking at what is your doctor's dream. My dream as a doctor must have good doctoring skills, which is really clinical practice and knowledge, so that my patient would be safe and satisfied. I'm using the word delighted with the care that I provide, with a professional attitude and a value systems served with compassion, tolerance, and sensitivity. This is my dream. This is my mantra. This is how I've been working, and I will continue to work for the rest of my life. Next slide, please. Next slide. Do I operate or you operate?
But I'll operate.
Yeah. So the outline of the talk is the need for training, and the second part would be sustaining and improving our practice in the hospital and in the clinic. So in order to do so, next, please. Okay, I need to look back at my journey 50 years ago. I'm now 70 years of age. I've been a medical student, an academic physician, a physician scientist, and now a college administrator, dean of two medical colleges, really one at the Apollo Medical College at Hyderabad and the other one at Chittoor, which is in Andhra Pradesh. I want to detail the failures and success in my journey with some of the examples from the past to the present so that you do not repeat some of these. And I hope that I would be able to help the physicians forge with your identities and avoid some of the errors and have your objectivity for your future career. Next slide, please. If I have to begin my life, I would like to say I was a student at the Christian Medical College, CMC Vellore 69. And this has been my progress till I superannuated at the age of 60 in the year 2012, and then subsequently moved on to the Apollo Medical College system at Hyderabad. What I wanted to show you in this slide was it takes about 12, 13 years for the making of a physician. And then after the making of a physician or a surgeon, the same time, okay, then he moves on to a super specialization, and he tries to find a niche or an area where he can contribute to the training that he has received. Then either you move into academics or you move into patient care and continue with the teaching, or you start doing full-time research, becoming a physician scientist, writing grants, etc. So it is a tough job if you want to manage all of the four, namely that of clinical care, teaching, publishing, and community service. But it was a challenge, and I really enjoyed it, and I want to take you through that so that you would also understand what it is when you progress ahead in life. Next slide, please. So these are the dreams. Now you look at the communicable and non-communicable diseases in India. I'm looking at it only from the Indian point of view at the moment. We have about, let's say, close to 10 million deaths. Okay. Now, out of those 10 million deaths, you will find more than the people dying, more important is the disability-adjusted life years. You as a physician or me as a physician would not like to be disabled with any form so that you cannot contribute what you have been taught to do so, and also the quality of life that you lead. So sometimes we look at it, what's more important, the communicable disease or the non-communicable disease training. Now, communicable disease, you would say, is infectious disease, which is transmissible, and non-communicable disease is not really transmissible person to person, other than through genetic mechanisms of hypertension and diabetes. So what you don't want is you want somebody to have a full, long life. And today, the life expectancy, if you are born today in India, it is 69.5 years. I crossed it, for I've got a bonus. I've got a 1-year bonus after exceeding the life expectancy in India. So now, having reached the age of 70, my life expectancy is another 13 more years. That is how you have to look at it. And so I can have a problem with infection, with communicable disease and non-communicable disease. Every individual can do so at that. Next slide, please. So what next? Yeah. Now, what would you? So, if you really want to be of service to the community or the people that under whom you serve, now you look at what are the common disorders that are there. Now, if I say that okay, ischemic heart disease or stroke is one of the common conditions. Yes, it is a common condition, but you look at in terms of the number of people being affected. Now you get ischemic heart disease and stroke only predominantly among those above the age of 55, 60, etc. But the other childhood illnesses and the hepatitis and tuberculosis, respiratory infection affect several people even before they get onto their comorbid conditions associated with diabetes or hypertension. Next slide, please. What I am trying to say in this is, you are serving a large or a 1.4 billion people, number of people. All of the, each one of them have their health problems. There's nobody here who doesn't have their health problem. So how are these people treated? How are they addressing the issues that they have? There are more than 300 symptoms that a patient could possibly have. I teach about 136 symptoms, and each system has got about specific cardinal symptoms of each in each of the systems. So now there are several people who are looking at the health of the nation. Now it can be in the government sector, primary, secondary, or tertiary, or in the private sector. And there are several traditional medicine practitioners. I don't find fault with any one of the group, but all that I say is, if they've got the knowledge and the clinical skills, you can handle your patients. And if you can build on your skills and your knowledge base, you can treat them better. So having said this, how do we train ourselves? Next slide, please. So now today we have got, I've written this article for our college newsletter. We've got the 4 ends. The 4 ends are typically the National Education Policy 2020 that has come out, which allows a lot of upgrading in your skills, twinning process, doing a combined MBBS and a PhD. Then you've got the National Medical Commission, which has replaced the Medical Council of India, who gives the regulatory body that gives us the degrees. Then you've got the National Board of Examinations that gives us the same degrees which the National Medical Commission gives us. But one is in the National Medical Commission gives degrees in the medical colleges, which is highly regulated, and in the National Board of Examination, it's also regulated, but it's also conducted in tertiary care hospitals, where the training and the teaching go on simultaneously. Then you've got the Niti Aayog, which gives us the ideas and the concepts of how the major educational policies should be conceptualized and put into practice or implemented. So this is one of the major changes that have occurred in the last 1 and 2 years, 1920, and we have adopted it. And in the undergraduate education, MBBS, we've got the competency-based medical education, which I will share. Next slide, please. So you see now we've got let's say close to 500 medical colleges, or some are functioning, some are not functioning, etc. We have over 50,000 seats in the medical colleges in India. And you see now 500 medical colleges, and globally we have 2,250, which is 1/5 almost the number of medical colleges in our country, 1/5 that in the world. Okay, next slide. So we've got a large number of medical colleges. Next slide, please. And what is medical education actually? Medical education is nothing but the methodical creation of the habit of thinking. Now we've got, next slide, please. So what do we mean by this? Now, when making of a physician, we've got the curriculum. We've got the really curriculum and syllabus is used interchangeably. It's only the body of knowledge. What is the body of knowledge that a medical student should know? Everyone is very anxious. They are apprehensive. They are even concerned and really worried and as to what is the medical curriculum for the future doctor. Yes, today's doctor, yes, we know. So what are the learning outcomes? Well, we want to be a safe and effective prescriber, no doubt about it. Nobody wants to kill a patient, and competent. And we have to reflect on our practice of medicine. Of course, the professional values, which I alluded to in my first slide as the dream of a doctor. Yes, I do want to get a PG seat. Yes, I want to be a part of a medical workforce, either independently or with a group. Yes, if given the opportunity, I don't mind training others in the right ways of practice of medicine. And above all, I want a good relationship with doctors, patients, and have a good educational partnership. So if these are the learning outcomes, next slide, please. What is the time frame that we have from the day of joining or until the graduation? Next slide, please. You would find that you, in this nearly 6,000 hours of theoretical and practical training, I have to give you the adequate basis of adequate knowledge of basic sciences, that fundamental. Vesalius was the one who discovered anatomy, and he was fundamental in teaching us the process of medical examination. So you start with anatomy, the physiology, the biochemistry of life, then you move on to the pharmacology, the microbiology, the pathology, and then the the forensic part of medicine, and then the community services that you can do. And you must have a good understanding of the scientific methods. And let me tell you very frankly, I do not start. I am a very good diagnostician. I say it again. But I do not make a mistake on the anatomical basis of where the symptom is originating from. I do not make a mistake on the physiological basis of this abnormal symptom that the patient has. I do not make a mistake in the pathology of this particular problem. Where I could make a mistake is in terms of etiology, my specialty being infectious disease, whether it is caused by malaria, dengue, scrub typhus, leptospirosis, in case of infectious agents, or what is the metabolic phenomenon behind this person's abnormality. So there I might make an error, but that can always be confirmed. But a good history and a good physical examination, 94 to 96% of the patient's diagnosis, I can put a framework to and say it belongs to this and this. It's only in the remainder 4, 5, maybe 10. I can't diagnose hyperuricemia clinically. I can't diagnose whether this patient has got a renal stone or hypercalcemia or hypertension or a metabolic syndrome like hyperlipidemia without getting the biochemical parameters. Nobody can say. There are very few signs, 1%, 2% of that. Now, the most important is very difficult to say when a patient comes and tells you, I'm not feeling well. It's a tough job. It's easy to find out why he is not feeling job. But to catch a healthy person and say that you are, to tell such a patient that you are normal is a tough, very, very tough. In other words, when he's saying I'm having this symptom and you're not able to diagnose, and you say that, very difficult to say that he is normal. So you must understand what it means to be a healthy person and what it means to be a sick person. Remember the health-seeking behavior of the patients coming to you in your clinic or in your hospital or in the medical college. It's all different. They come to you with a lot of fear. Number one thing that they come to you not only their symptoms, but also a bag of anxiety. And anxiety, well, whether this doctor would treat me properly, would he understand what I am trying to say? Would he help me solve it? Is he expensive? Would he cause me pain? The mind, the problems that go through it, or the thinking that goes through the health to the patient is tremendous. You cannot but believe it. If you have been a patient, you would know what is the anxiety. But if you've been an educated, erudite patient, then it's a little different. These guys, they don't understand. But most of our people don't understand what is the meaning of the symptom, how much it would cost. What would be the side effects of all of this? They don't do that. That is where a good doctor-patient relationship comes in. Next slide, please. Now we are trying to teach them. Next slide, please. Now you see now adequate knowledge of the clinical experience, disciplines, okay, prevention. Who spends time and money on prevention? So it's a dream of a doctor that my patient's population must remain healthy. If I can help them to be healthy, if they are smoking, tell them not to smoke. If they are drinking, tell them not to drink. If they're obese, tell them to reduce their weight. If they're not active, active, ask them to be physically active. And the training that we receive in medical colleges is a good clinical experience, but it should be done under appropriate supervision. That is why the faculty are being provided to the medical colleges in order to ensure that they've got adequate ratio of faculty student to ensure that they are trained properly. Next slide, please. And the number one way of making somebody study is to have a very active evaluation systems, formative and summative evaluation system. Now, all these are part of the new curriculum or the competency-based medical education curriculum, 175 hours, which I did not have when I had my training for 50 years ago. Okay, now all these are essential. Now it's just been put in as part of the curriculum in order to bring out a holistic doctor. Holistic doctor in the sense of good in sports, extracurricular activities, and professional development, etc. Next slide, please. Having said this, where are we teaching them the art of medicine, or where are we showing them the love of humanity? This is the skill that cannot be learned from any textbook. It has to come from within. When somebody says, who's a good doctor, and how do you become a good doctor? By having seen problems in the past, by having experienced a problem let's say within your own family, you might have had problems, etc. But kindness, how do I teach? How do I teach them tenderness, sympathy, empathy? How to give them the sense of wanting to give from your heart? What is altruism? And how do you explain that? Is it your survival or his or her survival? What is the spirit? This is something that needs to be taught to our physicians. If not, because nobody has comes with this kind of congenital knowledge or congenital mind to serve. It is your upbringing that helps you develop this. If you haven't had that upbringing, you can still manage to get each one of these instilled in you, but that is a process that only you would have to reason how to get it. Next slide, please. Having said this, you can have the medical ethics study, history of medicine, the study of literature, visual arts, anthropology, economics. What is cost beneficial ratio? What's the point in evaluating somebody and telling him, brother, unless you sell your house, you cannot have this treatment? Who would do that? You have to assess all of this and tell them, understand the background socioeconomic situation where these patients come from. Next slide, please. So you look at it as, yes, you can learn without a teacher. Yes, you can learn. You can do e-learning, but you have to make sure that the learnings from the different sources are authentic and they have been well curated and that they have been, let's say, reviewed. Skill labs for your head, eye, and coordination. Simulation lab to have your thinking process. What would you think? Because there's so many dynamic things happening. If the blood pressure is dropping, the JVP is going up, what would you think? If the blood pressure is dropping, the pulse rate is increasing, what would you think? If the pulse rate is decreasing, what would you think? If the blood pressure is increasing and the pulse rate is, so many combinations and are there, permutations are there. But how do you teach them to think of the entire process? Please remember, the textbook you study forwards. But the practice of medicine is backwards. You see phenomenon happening. You have to link it back with what you learned forward. So telemedicine, how do you communicate to the patient, and virtual classrooms? Next slide, please. All these are good. It will help improve but remember, every graduate has an aspiration. And what is their aspiration? Next slide, please. The aspiration that they have is, can I get a postgraduate education? When I showed you 50,000 students, and I'm telling you, graduate each year, and we have only 26,000 PG seats, let's say, and what would be the backlog, and how many people can get a postgraduate seat, and how many people can get into a super specialty seat? Let's say if the medical specialty, it's about 3,000 or 500 medical postgraduate seats that you have. You've got a family medicine. What is family medicine? Yes, most preferred or less preferred than internal medicine. But family medicine, you've got a full stop. You can go into super specialties. With the MBBS, with the MD, you can go into any of the super specialties. And why do you people want to get into the super specialties? Well, there is money, there is glamour. I want to serve more. I want to serve better. I want to have a better skill set. Whatever be the reason, we don't want to get into that. But all that I want to summarize, all that I want to say in summary is that we don't have that many postgraduate seats and that available in the country to supply to all the graduates that we have. Next slide, please. Now, having said this, why do we need such postgraduates? Well, septicemia and complications from devices, implants, grafts, acute myocardial cannot be managed by an ordinary MBBS person. You need special skills for it and special knowledge and experience by learning a more complex kind of medical, let's say, the drugs that you use, the combination drugs. So you need to have super specialists, no doubt about it. Next slide, please. And you will find, now you've got a lot of immunocompromising conditions. You need super specialists for that, not with your MBBS knowledge, not with your MD knowledge, but you need to have a higher grade knowledge in order to handle such patients. Next slide, please. Having said this, what is the difference between a physician and a specialist? Please understand this. This morning I was speaking to the radiologist saying, sir, you cannot make a histological diagnosis. You can make a diagnosis saying that the anatomy is altered, the contour is altered, Maybe the shape is altered, perhaps the texture of the tissue is altered. And you can say it's a group of lymph nodes. It is not fatty tissue. It's not. It doesn't seem to be a dermoid cyst or something in the mediastinum. You can say to some extent, but you cannot confirm. You cannot say this is tuberculosis. Please, never. Are you seeing the organism circulating? No. You are only seeing the maybe you're seeing a fibrosis. You're seeing a strand, or you're seeing some interstitial edema and things like that. That's all you can say. Cardiologists, they understand cardiac function better than us. They understand why this patient is getting a tachycardia, what caused the tachycardia, but they have to also act with precision. In other words, you can't just make a diagnosis of hypertensive heart disease causing the tachycardia, but you have to explain. They understand myocytes well. Nephrologists understand the glomerulus very well. They don't understand dialysis technology and transplant. Neurologists really understand the EEG, the EMG, perhaps the structure of the brain when they do a CT scan. A gastroenterologist is a discipline, visual discipline, I would call it. They can get to see your insides. A rheumatologist, they can do ultrasound of the joint and tell you whether synovium is thickened or not, or whether there is fluid or not. Oncohematologist, bone marrow transplant would tell you whether this person can be cured of leukemia. There are several leukemias that can be cured. Say, for example, chronic myeloid leukemia, that they can do it. Now, you can look at the markers and eliminate the markers. General medicine specialists would know about it, but would not take the challenge of trying to treat a patient with leukemia. Pulmonologists do endoscopy. Infectious disease, my specialty, they know more about microbiology and antibiotics. So you see, it's basically an internal medicine training program, and then you advance it. Now you look at competencies of a clinical infectious disease and a microbiology. Fundamentally, there are differences. One is skilled at bedside, one is skilled at bedside. 3 years of training. One is good research-oriented, the other one is practice-oriented. Some have good communication skills because you see patient eyeball to eyeball. Microbiologists don't see patients eyeball to eyeball. Next slide, please. And you will find, next slide. And then you can, the medicine people know how to evaluate non-infectious causes. Microbiologists would handle the evaluative or the so-called organism well. We have clinical localization, they have molecular mechanism. So you see there are differences in the training competency of a microbiologist, the infectious disease specialist, the radiologist, etc. Next slide, please. Having said this, now if you look at the community base, now for example, TB, previously we used to just treat a patient with TB anti-tuberculosis drugs. Today they question, because you've got drug-resistant TB, you've got mono-resistant TB, multi-drug resistant TB, and it's no longer a simple science. You have to analyze and see what is the susceptibility of this organism, rifampicin or non-rifampicin susceptible. Next slide, please. Having said this, so this was not taught to us in medical school. And then you've got point of care testing. Everybody wants a precision in your diagnosis so that you can treat your patient better. So when you want to treat your patient better, you must have a laboratory confirming your clinical findings and your clinical history, not the other way around. You don't start with the laboratory and then say whether the history and the physical findings conform to what is found in the laboratory. No way. That's the wrong way of thinking for a doctor. And that should not be the dream of a training physician. Next slide, please. And then, so research. Very few of us practice research or even have publications worthy of what we want to add new knowledge, new information, and study in depth, because it's not taught to us in medical school properly. It's not taught to us even in the postgraduate education. Only after you become a faculty, do you understand the nuances of research. Next slide, please. And then begin to publish as such. Now, I've got a great deal of publication, but I learned all this, how to write a grant, how to write an abstract, how to write an editor review. It's all a process of learning, which you did not do it in your undergraduate, nor in your postgraduate, and perhaps in your early consultancy days. Can't draw a figure, not to have a design, how to write a table, how to write a structure and flow of the sentence. Next slide, please. This is what you need to do if you wish to be an academic physician. Now, having moved forward, you finished an undergraduate, you became a postgraduate. Now, you didn't become a postgraduate, you want to practice medicine. You can still do it without a degree, provided you're up to date in your knowledge. Knowledge is really not knowing it, everything in your mind, but knowing where to find it. You can have evidence-based knowledge, you've got guidelines, you've got clinical decision support system. What is the sensitivity, what is the specificity, and what will be the outcome of the patient? Would there be cure, or will there be partial cure? Will there be total remission in a cancer, or will there be a partial remission? These are things that you have got data. You take that data and apply it into your practice, provided you are willing to read. Next slide, please. So there are systems established for us. So you have to stay invested in knowledge. Whether you're writing a postgraduate exam or a USMLE exam, you want a daily practice, whether you want to use, there's so many things that are happening. But let me tell you one thing, you really have to, I'm a grandfather now, and you really have to spend an hour each day in order to read, in order to stay abreast of what is happening. Of course, you attend CMEs, of course, you attend classes. When I have to prepare, today I prepared for this lecture, or so-called, how do I put it? I still had to read something. I can't just give a talk without preparing. Forget the slide quality. I'm talking about what am I going to say as such. So it takes time to read and do things. Next slide, please. So you have to remain. So which way do you want to go in life? You decide. You want to be a clinician or clinical practice. You want to be a researcher. You want to practice. It's your choice. Why do you have this choice? Next slide, please. The reason why you have this choice is that you want to fulfill your ambition or your aspiration. Everybody has a dream. Everybody has a dream. You want to live a full life. I want to lead a full life. Okay. You want to know what is happening around you. Okay. Now, this is a very powerful motive. Money is a very powerful emotional motivator. Okay. Be careful about it. Does it give you happiness? Think about it. Okay. Spirituality can also get you happiness without much cost as thought. Next slide, please. So having said this, you have to decide your happiness factor. All doctors, anybody in the world must have a happiness factor. No, is it the economy around you is improving, or the economy around you? We all had a problem during the COVID time. And the economy really slumped. The environment, and then good governance. What was it? How many people went out with mask and transmitting the illness, or getting the illness and the infection and going back home? You must look at the domains. I want to be psychologically happy, educationally happy, living standards, use of time. You have to decide what are the domains under which you want to find your happiness. And then your indicators. To me, I would say time spent with family as against time spent at work. I have spent more time at work than I have spent with my family. But of course, you live with them, you stay with them. That's a different ball game altogether. But do you understand the needs of your children? Do you have the compassion as you had developed for your own children, for your own patient? Do you have the generosity of giving to your children, the feelings of frustration with your patient, frustration with your family? These are all part of your happiness factor. And you have to learn to leave work at home, or learn to leave work at the workplace, and then come to a good work-life balance. Next slide, please. So now, having said that, what motivates us? Well, I want a sense of achievement, esteem, actualization. Okay, Dilip, that's fine. 35. After having spent 40 years, you would like to have this. A sense of fulfillment. I have done this much. Very good. Reasonable financial health, not a great financial health. Long-term job security, that is something that each doctor is assured of. Long-term job, because you are a professional, you can manage. And please understand, you have a brand image that is stable, and you have to make it grow. Because nobody else can make your brand image go, but you have to do that. So these are the things that motivates you. Next slide, please. The last few more slides, I just want to talk. I just wanted to summarize. So you need the training for you to practice your art and science of medicine. You need to sustain yourself and learn how to improve your practice at hospital, and you have to stay invested for the future. Next slide, please. And you will find, next slide. And what is success? You determine whether it is achieving your goals, acquiring your wealth, prestige, favor, or power. You decide for yourself. Next slide, please. Because if you don't achieve the success, next slide, you just have a good life. You want to be, when you're a failure, nobody would listen to you. Nobody moves. You don't attain material success. You're rejected by people. So you weigh between success or failure. And then you look at what motivates you. You look at what brings you happiness. So these are all the things that play around to make the dream of the doctor. And finally, next slide, please. Now, next slide. So you are what you do and not what you say you will do. Okay, so you do your best and whatever you can. Next slide, please. So when my hope for the future, so the doctor's dream, I have just summarized it for you, and I think I've given you some examples, but the time limitations prevent me from moving further on to this. And next slide. So my hope for my future, next slide, is I'm hoping, next slide, please. Okay, is keep reading, and this is my hope for the future. This is my grandson, whom I thought would make him into a medical person. He's now 17, 18 years old, and what he told me today was, next slide, please. Next slide. Okay, I told him that you've got to read all these books. Previous slide. Okay, read all these books. He said, no, thank you, and wish you a happy Doctor's Day, Appa.